Hello, so this is a nice small group. Are any of you printing anything in-house, just so I kind of know what printing models, printing aligners, printing models? Sorry? Okay, good. So I'll just give you a little background about myself. I graduated about 20 years ago. I was full-time academics for a long time. I was private practice and full-time academics for a while. And I was program director at Harvard for about 8 years. I still go back and teach there once a month, and I teach at Howard once a week. I'm involved with Titan, I'm just disclosing that. And I'll give you a little background of my journey with clear aligners, because I started out, believe it or not, I started out with positioners when we used to cut the teeth on plaster and make spring aligners and that kind of thing. And I was involved when Invisalign was just starting up. We became Platinum Plus Invisalign providers. We won that Invisalign challenge multiple times, both as a faculty and in private practice. So I know how Invisalign works, and I think when we had good results with Invisalign, I felt like it was despite the software and not because of it. So I'll talk to you a little. I'm going to show you one of the cases that won the Invisalign shootout a few years ago in the teen category. And this is a tough case, especially for aligners. It's a tough case. Deep bite, low angle, class 2, retrusive lips, retroclined incisors, blocked out lower right first premolar, blocked out canines. There's a lot going on. She's almost full cusp class 2. So she treated out pretty nicely. And when you go to the Invisalign shootout, they censor your slides. They have to go over all your slides, and they make you take out anything that makes it look complicated. They want people to think that you send this to Invisalign and it comes out looking like this by magic. And it's not like that. I'll kind of show you, what we went through to get there and some of the challenges involved and what we do now to kind of avoid some of those challenges. So what they don't tell you is that this case had, the first round of aligners had 54 stages. And it had 21 setups. So I had to go through 21 setups to get this case looking from here to there. I had to go through 21 versions of ClinChecks to get it there. And I'll show you some of the initial ClinChecks that they sent me and some of the problems we had with those ClinChecks and why it never would have worked. If you just send it to Invisalign and you approve what they give you, it does not work most of the time. And I'll show you why. So this is the first setup they sent us. So if you notice there's a tooth there that they just deleted. That lower right first premolar, the blocked out lower right first premolar, they just deleted that tooth. And usually we don't remember this stuff. Like, you're going to open ClinCheck, it's easy to miss that. It's easy to miss that they just deleted a tooth there. And if you approved the setup that they gave you, now they give you a pontic there, but if you notice, the pontic doesn't appear. The pontic there doesn't appear until aligner 20. Aligner 1 through 20 are not going to fit. The edge of the aligner is going to bump into that first premolar, and the aligner won't go in. So if you just approve what Invisalign gives you, it will not track because they just deleted a tooth. We had the same thing here. I saw an opportunity here on that right side where the upper right canine is buccal and the lower right first premolar is lingual. For me, that's a perfect opportunity to wear a rubber band from the upper right 3 to the lower right 4 on the lingual. So I asked them for that. But despite me asking them for a button on that canine, if you look at the setup, they just deleted that. Both canines were deleted. This is pretty common. You send stuff to the tech, and the tech just deletes anatomy like that. And they don't tell you they deleted the anatomy. You just find out when you deliver the aligners that you missed it, or you didn't look at the photos, or you didn't check the scan. See, here they were giving me 61 aligners. One of the things that I really noticed when I started doing my own setups and started manufacturing my aligners in-house is that cases don't need as many aligners as I thought they did. I used to think 50 aligners or 40 aligners was normal. That's all I knew. We didn't know better. When I'm doing my own setups, I'm realizing that the same case that I'd sent for a clinch check and get 30, 40 aligners, I can easily do in 15 or 16 aligners. And I'll show you a demo and show you kind of some of the ways we can get the number of aligners to be shorter, fewer number of aligners, because things track better when you have fewer aligners. And most of those extra stages are AI trying to eliminate interferences. So they get an interference or a mid-course collision, and we have those tools, the AI tools, and I'll use those AI tools that avoid mid-course collisions. But 9 times out of 10, it'll double the number of aligners. And you can always find a better way to avoid the collisions than the AI. And I'll show you a demonstration of that in a little bit. So here's another thanks, I think it just died or something. No, this one's not working.
That one's not working either.
No. Okay, sorry about that. Can you hear me? No, it's not. Okay, hello? Can you hear me? Yeah, okay. No, not really? I'll speak up a little. You can't hear? I'll just speak without this and speak up higher. So if you look at the canine over here, look at what happens to it as it erupts. So they finally give me the canine. So I ask for another setup. They finally give me the canine that they deleted earlier. And look at what happens as it erupts. So the canine gets skinnier as it erupts. We all know that the unerupted part is bigger than what we see. But if you look right there, right around the liner 20 to 30, it's going to stop fitting. Because they have the anatomy they have the canine constricting, where in real life it should be getting wider. And they said that's a software limitation, there's not much they can do about it. The workaround is to ask them to erupt it with the gums. But there are lots of issues like that you really have to pay attention to, otherwise it will not track. So here's that tooth that they deleted. They eventually gave me a pontic there earlier. They still wouldn't give me what I actually wanted. And then at the end they gave me this. They gave me a part of the tooth. They gave me the whole tooth, but they wouldn't let me put a button cut out. So they said that the height was not high enough to allow you to get a button cut out. The workaround there is to ask them for a gingival margin modification. You ask them for a gingival margin modification, and then you have to remember to put a button there. They can't put a button cut out there for you. So we ended up with 54 stages, and we finally got what we wanted, but that wasn't until plan number 8. So we went through 8 different plans to get to a plan that was workable, that I thought would track. So like I said, this is over 100 aligners, 21 setups to get from here to there. It's not magic that just goes to Invisalign. And some of the challenges I had with Invisalign that I complained about for years was the setups had problems like that. They delete anatomy, eruption compensation, and limitations of where they can put buttons and button cutouts. I had no control over the staging. With the 3D controls, I could only control the end. I couldn't control how they got from point A to point B. And I couldn't integrate with any fixed appliances. There are lots of, I don't feel like I have to pick between braces and aligners. I think it's a continuum, and I think every case that can benefit from wires should use it, even if the patient wants aligners. There's no reason I can't use both of them at the same time just because the company's motto is clear and wireless. That shouldn't restrict us as orthodontists if we want to use wires together with aligners. So I had a couple of patents. One was related to 3D facial diagnostics. One was related to hybrid orthodontics, where we use aligners with tunnel attachments that accept wires. And with some of my buddies, Mario and Frank, we started Titan. And we had a lot of the things that were bothering us about. Mario's also an Invisalign user, and we both kind of had a lot of things we were frustrated about with Invisalign. So we kind of created something that would solve a lot of the issues we had with Invisalign. So you can take a 3D facial image off of an iPad or an iPhone, and you can instantly integrate it with your diagnostics. It has automatic landmark recognition. You can integrate it with a CBCT. So you have a virtual patient where you can kind of decide where you want the teeth based on where the soft tissue is, where the hard tissue is, etc. So it's nice to have that information, that diagnostic information, while you're moving the teeth. These are tunnel attachments. You can have them on the buccal or on the lingual. If there's a tooth that I don't think is going to track well, I'm putting some tunnels and I'm putting a wire in there to help the aligners do what aligners are not very good at. And you can have them on the buccal or on the lingual. You can have them whatever segment you need them. So when we started designing aligners ourselves, we started printing them the traditional way. In the office, we print the models and have the vacuum form aligners on them. And our staff wanted more hours, so I'd rather pay my staff than pay an outside lab. So initially we were having everyone in the office work on weekends, and they were making printing models and vacuum forming aligners. And then at some point they told me, this is too much. It's too much labor, it's too labor intensive, it takes a lot of time. They're working all weekend, and we kind of reached a happy place where we said, okay, if it's 8 aligners or less, we'll make it in the office. If it's more than 8 aligners, we'll send it to an outside lab to make. It was nice that we could give patients aligners same day or next day if needed. The aligners adapted better. I didn't realize how baggy Invisalign's aligners were until we were making our own aligners. They grip the teeth a lot better in general, because the Invisalign blocks out, because they don't want anyone complaining that the aligners won't come off. So it's a one-size-fits-all. So they make all the aligners a little bit baggy. Whereas when you're making them in-house, or if you're direct printing them, you have a choice, and you can decide how baggy or not baggy you want them to be. So if we've got little kids that are phase 1 with really short teeth, I've got a code with my lab. I'll tell them R0 means no block out at all, and I want them to grip with like 0 block out. And if it's an older patient, I can increase that blockout level to make it easier for them to put them on and take them off. There's a lot of plastic waste involved with these, even with Invisalign. Every aligner has a model that gets thrown out. It's a lot of plastic waste. So that was one of the problems we had with that. And it's very, very labor intensive. When we had everyone making stuff in the office off of models, they'd complain of carpal tunnel, their wrists hurt. After a while, they were all complaining of cutting and taking them off the models and trimming and all that stuff. So that was those are some of the issues we had when we were printing printing the models and thermoforming the aligners. Honestly, switching to direct printing was a game changer, because that's where we completely moved everything in-house. That's the point where we stopped sending anything outside. It's a lot less labor intensive. There's a lot less plastic waste. It's locally produced. I don't have to worry about UPS or weather delays or a snowstorm. If we need it, it can be ready in 2 to 3 hours. It can be ready. The shape memory plastic has been really nice. The only difference in my workflow in the office is I tell people that to put instead at night when they're having dinner, instead of putting their aligners in tissue and losing them, to put them in a cup of hot water with a polydent to keep them clean and to reactivate them. So like they're making a cup of tea, they put them in a cup of hot water and that reactivates the aligners. And the patients feel the difference. When they put them in, they're tight again. They'll tell you it's like a fresh aligner coming out of a packet. Things that I didn't think about when I switched was that you've got variable material thickness. So you can make the aligners thicker in the front than in the back. So now we always struggle with aligners in general when patients close, or with SX retainers that they touch in the back before the front and develop that little bit of posterior open bite. With direct printing aligners, or retainers, you can make them thicker in the front than the back. You can make the plastic a little bit thicker in the front than the back, so you don't have that issue. The other benefit is that you can print the buttons for the rubber bands. We waste so much time in the office. Wasted so much time in the office teaching patients to wear rubber bands to slits on the aligners. It was a colossal waste of time. Once you have buttons on the aligners, it's so much easier for the patients to put the rubber bands on. And since you're direct printing, you can print anything you want. So you can print a button coming out of the aligner and the patients wear the rubber bands to the buttons. It's so much easier. So this is the patient I'm going to do a demo on. Yeah, okay. So this is the patient I'm going to do a demo on. And anyone that's treated a lot of patients with aligners will tell you that upper lateral incisors are the toughest teeth to move, the terrible twos. They don't respond, especially if you're trying to extrude them. So I'm going to show you a demo on this patient. She was treated with direct print aligners, and she was designed on Titan. So I'll give you a little demo and show you the whole process. Just for the heck of it, I sent it to Invisalign just to see how many aligners they'd give me. So it was 33 stages. And I'll move the teeth for you right now, and I'll show you a demo, and we'll get it to about half of that or less. So this is her after 17 stages. 6 months, 17 stages. And I was really surprised how well those upper laterals tracked. The laterals tracked really, really nicely. And this was her after 1 refinement, 6 stages. So it was 17 stages followed by a 6-stage refinement. And that's it. We just debonded her this week. We took her attachments off this week. So I'll show you a setup and show you how I set her case up. So Titan integrates with iTero, with 3Shape, with RunYes, with all sorts of different types of scanners. But this is off of iTero. I have an iTero in the office. So it shows me all the scan dates. I don't have to export the models and import the models. I don't have to do any of that. I'll just go to the patient. It searches the name. It finds all the scan dates, and I'm gonna do it live here. I'm gonna click her first, so you can see her first scan was March 28th, 2024. So I'll pick that. And I don't have the best internet, but it's still loading pretty quickly. So it's basically going into my iTero, bringing the model, uploading it here into Titan directly. I don't need to export, I don't need to upload, none of that. Okay, so this is what we've got. So the steps in the top take you move you forward in steps. This moves you backward in steps. So I'm going to orientation. A lot of it is AI driven. So in the old days, we had to mark every tooth. Now the AI locates all the teeth. You have to check it to make sure that the dots are on all the teeth. That's the maxilla, mandible. You just want to check it and make sure there's a dot in the middle of every tooth. The segmentation is also automatic. In the old days, we had to do a lot. There's a lot of manual segmentation. Just a sec. So it's it's automatically segmenting all the teeth. It's automatically numbering the teeth. It's identifying what tooth is what. Again, you want to check it once in a while. There's a mistake and you have to correct it. But just make sure that the tooth numbers are all correct. And that looks good. You want to check the long axis of the tooth. So it sometimes gets some things wrong here. So you see the tooth is rotated. You want to get the long axis of the tooth to be correct. That way when you click mesial, it actually moves mesial. It doesn't move buccal. So you want to just check that and make little adjustments to stuff like that. Again, the AI does most of the work for you, but you still have to check it because there are mistakes. You can load a face scan. If you use your iPad or your iPhone to capture a 3D facial scan and you want to load it, this is the place to do that. So it's just uploading her facial scan. And again, you'll need to adjust it a little bit, but it gets you close. You have a Bolton analysis, just to look at tooth size discrepancy to figure out approximately how much IPR you're going to need to do. So you have those tools there. You can compare the patient's face to the norms. We developed the norms a while back and we integrated them. There's age and race specific norms, different gender norms. It's not a one size fits all for the face. So I'll take you to moving the teeth. So now everything's segmented and it's time to move the teeth. I'll try to do this with one hand, sorry. So my strategy here, let me just undo that. My strategy here is that she's a little bit class 2. We have an anterior open bite. I want to slightly derotate, distalize, and intrude the molars so she closes down a little bit. And I know if I do that, she might contact in the front. So I'm going to do a little bit of IPR to retract the lower incisors a little bit so she closes down, auto-rotates into class 1. So that's my primary strategy in the back. And I'm pitting the distalization of the molars against proclination of the incisors. So the laws of biomechanics apply here just like they do everywhere else. So if I'm proclining the incisors, I want to pit that against a little bit of molar distalization. And the most challenging movement here is going to be the extrusion of the upper lateral incisors. And if I pair that with retroclination of the incisors, I know it's going to track better. Because retroclination of teeth generally tracks really well. Extrusion doesn't track that well. If I pair a more difficult movement with an easier movement, it generally tracks a lot better. So I'm opening space around the upper laterals. I want the plastic to grip the laterals all around, and then I want the plastic to extrude and retrocline the incisors at the same time. In the lower, I want to create a little bit of room for the plastic to grip that tooth, move that out a little bit, and retract the other. So I want the line of occlusion to be somewhere, the incisal edges to be somewhere between this incisal edge and those. So I'm going to procline this a little. So in the beginning, I usually start with the lower. My lower is my rate limiting arch. I'm usually starting with the lower, deciding how far forward I want to go or how far back I want to go, and I'm lining the teeth to that final position. Don't worry about mid-course collisions in the beginning. In the beginning, you just want to line the teeth up, get them where you want them, and then you can worry about mid-course collisions and IPR. But just start out lining the teeth where you want them to go. So I know I want that canine a little bit more labial. And you've got these, you can control it here just like you do with Invisalign and with 3D controls, or you can use, this to move them out a little bit. You can use this to move that out. So I'm just going to do a quick, rough and quick setup for you. And again, I'm deciding where I want them to end up. I'm uprighting that central. And while I'm doing this, I'm thinking about where I want attachments, the teeth that are moving the most, that are going to need some attachments. Hello? It came for a little bit. It's okay. Alright, so in the upper, I'm derotating the molars a little bit. I know I'm going to need to derotate them. It's back. I know I'm going to need to derotate the molars a little bit to help with that class 2. I'm expanding the premolars and derotating them a little bit to also help me with my class 2 relationship. I want to get that non-functional cusp out of occlusion. So there are AI tools to help you do this, but for me, honestly, it ends up taking me just as long to just move the teeth directly to where I want them to go. And compared to sending them to a setup, to Invisalign or whatnot, the number of times I go back and forth and the time I waste trying to figure out what they did and undoing the things that I don't want, it ends up taking me just as long to just move the teeth directly to where I want them instead of undoing things that I didn't like. So I'm proclining those upper incisors, and I know that's going to be pitted against the distalization that I'm doing on the molars in a moment. And those laterals I'm retroclining. A little bit less on the left one than the right one. And again, over here, I want those molars to intrude. And I'm going to finish with a little bit of a posterior open bite, because I know in real life, the patient's not going to walk around with their mouth open. They're going to close, and you're going to get that class 1 relationship from a little bit of molar intrusion and distalization. Now, you can send it for somebody to do the design for you, but it honestly doesn't take that much longer to do it yourself. So blue is a space, red is a collision. So you can just X out of all these collisions. Again, I'm extruding that lateral. Okay, I'm going to get rid of all these spaces and collisions. And we're pretty much done. We're close. So in real life, I'd probably spend a little bit more time on this. But I'm getting rid of all the spaces and the collisions. In the lower, I know I want to do a little bit of IPR because there was a little bit of a bolt-in discrepancy. And I know I'm finishing with a little bit of an open bite. That's going to close down with some mandibular auto-rotation. So I'm okay doing about 0.2 or 0.3 millimeters of IPR, lower canine to canine in this case. Again, you could look at your tooth size discrepancy and decide exactly how much you want to do, or take a look at the fit and decide for yourself. Okay, now those orange boxes show areas where I've got a collision. So if I just make these aligners, it's not going to work, because I'm only doing 0.2 or 0.3 millimeters of IPR, but in real life, there's a ½ millimeter collision that's occurring here. So as you go so at the end, there's only 0.3 millimeters of collision. But if you look over here, at aligner 6, that's when it's going to stop tracking. And that's what that orange box is telling you. It's telling you that you need to do 0.3 millimeters of IPR to get them looking like that. And again, I usually want to over-treat a little bit, so I'm going to just move that tooth out a little bit more. But this is telling me that there's 0.6 millimeters of mid-course collision. So as you're getting from point A to point B, the teeth are interfering with each other, and it will not track. So what you need to do to avoid that is create a key. So I'm going to stage 4, and I'm going to create a key. So you have to unlock, so you go to advanced mode. You go to stage 4, and I'm going to create a key here. So you go to the bottom timeline, you click plus, and you create a simple key. What that does is it creates a key or a time point where I can avoid those collisions. So I'm going to create some spaces between the teeth. I'm going to advance the teeth a little bit, move them a little bit away from that area of mid-course collision to avoid that collision. So I'm okay, since I'm planning on 0.3 millimeters of IPR, I can move those teeth away from the collision by less than that amount of the IPR that I'm doing. So I can move this back a little, move that distally a little bit, and all of a sudden that collision's gone. So I created a stage 6, where they're expanding a little bit. You get a little bit of space to give them room to line up without bumping into each other. If they're bumping into each other in mid-course collisions, the aligners will not track. So I'll do something similar on the upper. We've got those mid-course collisions there. Sorry. So I need to avoid those mid-course collisions. So I'm going to create a transitional stage here, stage 6, where I just distalize a little bit earlier. So I'm going to go to the plus sign, simple key, and just distalize a little bit. So what that does is it's accelerating the distalization movement, so they happen early on in treatment. So that key, what it's doing is I'm forcing these teeth to go to their final position a little bit earlier, so that we can avoid those mid-course collisions. So I'm creating an intermediate position, like a waypoint. Like on a GPS, you're creating a waypoint where you're having the teeth take that stop, go to that position before going to their final position. And what that's doing is it's giving you room for those laterals to move with space around them. I want extra space. I don't just want to avoid the mid-course collision. I want extra space around those laterals. So I'm moving the teeth around the mid-course collisions away from those orange boxes. Now, there is a button to get. There is a button to do this automatically. So this is what I was saying about the fixed mid-course collisions. If you want to do this automatically using the AI, there is a button that says fix mid-course collisions. So I could get rid of this altogether, and you go to fix mid-course collisions, it'll automatically do what we were doing. Now it increases the number of stages a little bit more, but 17, 18 stages are not unreasonable for this case. If you were to do it manually, you could probably get it a little bit lower. You could probably get it to 14 or 15 stages. But if I usually use the AI, I'll have it show me what it can do to avoid mid-course collisions, and if it's not doubling the number of aligners, I'll use the AI. If I find that it's increasing the number of aligners to 40 or 50 stages, I'm doing it manually. I'm doing what we did in the lower there, where I just created a key so that they'd move a little bit away from the mid-course collisions. Next thing I'm doing is attachments, and you've got some, you see it's giving you a warning that there's a lot of extrusion on those lateral incisors, so it's suggesting an attachment there. And the attachments auto-orient to the force. So the force is that blue line that you see, that's indicating where the force is. And you see when I change the position of the attachment, it changes the orientation of the attachment. So it lines up the attachment with the line of action of the force. You can override it, you can change it to whatever you want, but that's where it defaults. And you can adjust the size of the attachment or the length of the attachment or the profile based on your preference. You've got a lot of attachment shapes that you can use. You've got buttons for, class 2 elastics. And you can orient them so that they work. If you want, this is not a case where you need ramps, but if you need ramps, that's where you would add ramps if you need them. This is actually a case that can benefit from lower occlusal ramps. So sometimes if I want to intrude the molars a little bit more, I'll put ramps on the lower molars. Just to create a prematurity there to help intrude the molars. And once you're ready with it, you're happy with your setup, you go to your tags, you can go to lab labeling or manual labeling, and it automatically defaults to the name of the patient and the number, aligner number. If you put it on the tooth, it's just the number. If you put it on the base, it's the name of the patient. You can adjust the cutting line, especially if you're direct printing the aligners. You want to make sure you're happy with the cutting line. If you want it a little bit higher, you can move it a little bit higher. You can adjust the frenum. You can adjust the scalloping. And then once you're ready, you go to create a print order. So I'm creating a print order, and this is nice where you decide how many days you want per aligner, because it's not going to force your lab person to print all the aligners at once. You don't want them to waste the whole weekend making 18 aligners when all you're delivering is 6, let's say. Especially if the patient's coming in the same day or the next day to pick up aligners. So you can say how you want to batch them. So we want to give 6 aligners at a time, let's say. And I pick whether I'm doing it in-house or at the lab. So in my situation, I've got a LuxCreo printer in the office. So I'm printing in-house. I'm saying I want 6 at a time. And I'm saying that I'm doing 10 days per aligner. And if I want any special instructions to the lab. So in this case, I'm doing our retention 1. I'm telling my lab person I want retention level 1. Retention level 0 is no block out at all. So at this point, and you're just checking the batching. So it has the dates that the lab is going to print every one of these batches. So they're going to have it in their queue. The first 6 aligners are going to be in queue, right away, but they don't have to print the next batch until June, and the batch after that until August. And I submit it. I think we have a bit of an internet problem, but I'll show you how the lab person then picks it up. So I'm done doing what I'm supposed to do. Now our lab tech uses a different module. Our lab tech uses the printing section here, and he has what's in queue for him. So this is what's in queue for the lab. So he can go to, let's find that patient. Sorry about that. So he's exporting the first batch of the aligners. That's what's in queue for him now. So this is the module that the lab person is using, and it's just grabbing the batch that's due at this time. And it integrates with LuxCreo, where it creates a format that works that's compatible with LuxCreo. So when he goes over here, he can pick what format. Does he just want to do a local STL? Does he want a shell? Or does he want to send it to a LuxCreo format? So he can click LuxCreo, and he can decide how he wants to print. Vertical, horizontal, etc. And he's going to export, and he's going to have a file format that then he can use with Lux Design and LuxFlow, just like you saw earlier. So that's the workflow from the scanner stage up to the point where you have a LuxCreo file that you then take to Lux Design for printing. So I'm happy to take any questions, but that's my workflow. I'm sure you're going to find something that works better for you, but that's my workflow for cases like this.